morning.
How are you?
I'm great and yourself?
I'm well. Wait, let me see. Okay, I don't want to touch nothing because you said everything sound good.
It
I
does.
I'm not touching anything. It
It
is
does.
good. Good morning. All right, all right. Happy Saturday.
Yes.
Yes, yes. Look at us on a Saturday morning, spilling all this tea. Lord, Lord, Lord. How's your week been?
Well, whenever there's a holiday on a Monday, the week flies by.
Yes, it does.
It really did.
And I feel like I'm playing catch up at that point. Like,
Right.
you slipping into my other hours. What is happening here? So I always feel like it's a catch up situation. But it was cool, productive.
Good.
I love
That's
being productive. That's the good thing.
that's what
That's
it's all about.
what it's all about at the end of the day, and being productive for me. All right, all right. Well, let's get this party started. Welcome, welcome to our Saturday morning tea where we discuss health information, news, education, certification, tips for certification, tips for just living in this health information world, entrepreneurship, the revenue cycle at large, just all things happening. Um, And while we primarily focus on, I saw something on somebody's page recently that was like they primarily focus on the middle revenue cycle. And I guess we primarily focus on the middle revenue cycle, but we hit all ends, front and back. Trust and believe, we hitting it all from the rooter to the
Right.
tutor.
Yes.
Because it's all relative. It's all relative. So as you come in, don't forget to hit the thumbs up or like button. I am Clarice Warner. I am the girl with the pearls, the founder and senior education director of the Professional Reimbursement Network, LLC, where coding education is key. Let's sit on that for a minute. Coding education.
Key.
Key. PRN is a healthcare compliance consultancy located in Cincinnati, Ohio, that specializes in revenue cycle and regulatory compliance and education. Now, let me ask you, do you know what it takes to be a certified, marketable medical coder? Do you? Well, before I introduce my co host, let me share with you information on a free email course on the 5 steps to become a certified, marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified, marketable medical coder. Learn more at bit.ly/5stepscoder. All right, all right. Turn this back down just in case. Look, we've been trying all of the things. All of the things. If you are interested in getting more information about the 5 steps to become a certified marketable medical coder, well, then check out the link in the description box. If you are on Clubhouse, you can check out the link that is pinned to the house page, whatever this is. It's pinned. You can get it. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Put some respect on his name, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia, Pennsylvania. I have been in healthcare and nursing for quite a long time, 30 years. I transitioned into HIM in 2014. During the pandemic in 2020, I created a company called the Coding Nurse LLC, where I help nurses and other healthcare professionals with clinical backgrounds transition into the wonderful world of HIM.
Yes. And how's that going, sir? How's it going?
It's coming along slowly but surely.
Yeah. I believe what is it? Slow and steady wins the
Wins
race.
the race, yes.
Yes. I have to get my quotes ready. Get them right in my head. Get them right in my head. Yes, yes. I believe
Because
that. I believe that. And,
because
and
I'm in,
go ahead.
go ahead.
And I believe that it's also a sweeter reward when you proceed that way. So and you appreciate it more for the work that you put in to get to that level. So I'm a firm believer in that. But go ahead.
Definitely. And I was just want to say that I am running into more and more nurses who have admitted that they have tried to learn medical coding on their own and they can't.
Really?
See,
Well,
people,
look at God. Just look. Confession, testimonial.
yeah,
I love it. It's good for the soul.
yes,
Well, I'm glad. I'm glad. Yeah, people think it's it's just, oh well, I can just do this. I'm teaching,
hmm
and one of my students talked about that. Oh, I just thought we could just do this, that, and the third. No, sir, and no, ma'am. That's not what you can do. It's way more to it. I always talk about the why behind what's going on, and it's way more um, complicated in the background, yeah, if you will, than folks think. And so, yeah.
and uh, actually, I just started another class on Thursday, and I have a nurse practitioner who started her own home health agency, and she took the course because they changed the PDGM,
Mhm.
their payment methodology, and like I was explaining to her, I said PDGM is really nothing but risk adjustment for home health. That's
Yep.
all.
And that's why, yes. And so understanding what risk adjustment is and how that world, and did they explain it that way to them? Probably not.
No, not at all.
Probably not. But then want to catch them in a whole trick bag because home health has um always been hot, hot, hot. That low lying fruit that they come get. You talking about the cobbler? They ready. They pulling that fruit, making that cobbler real quick. I don't understand. Okay. Well, before we jump in today, let me remind you that you can join in and add to the conversation, and we look forward to you doing that. So don't be shy. Your opinion matters here and is welcomed here. For those joining via Facebook, YouTube, and LinkedIn, you can use the chat. You do that on a regular basis. Um, if you are joining on Clubhouse, then you can raise your hand and we will bring you to the stage so you can see the magic on the stage.
Definitely.
If you are using the chat function, please place a Q first so that we know that it is an actual question for us and we don't miss it. So, for those who are just joining us or watching the replay, I know what time it is. Yeah. Nothing like MLK in the morning.
Nothing.
Why have I been making fans? That's all other conversation. For organizations. Make me a fan. Sure.
That is cool.
I'm now the fan maker. All right. So our church announcements for today. Wait a minute. A little break. Good morning. Good morning. Nothing like an organ. I knew how to play the organ. I Okay. So, church announcements for today. Um, the CMS, and this is kind of hot off the press. CMS has moved some items on their site, believe it or not. So, I got this information from Lippman Education, and CMS websites changed where they normally post the ICD-10 code sets. They just changed it like Thursday morning, September the 7th. So this is hot tea off the press. The new location is a section on the CMS website called Coding and Billing. So that is where uh, they have now moved it. If you are viewing this on YouTube, the link is in the YouTube description box. The direct link to ICD-10 PCS and ICD-10 CM. So if you want to kind of navigate and find your way, if you go to www.cms.gov, you can select Medicare on the upper left-hand corner. Select coding and billing from the left navigation menu. Select the ICD-10 codes from the right selection options, and then you can select the code set you're looking for, either the 2024 ICD-10 PCS or 2024 ICD-10 CM from that navigation bar. Remember, your 2024 code sets take effect October 1. Lots of changes happening in them, new codes all around, some guideline changes and updates, just a plethora of information that you should know going into October. Mr. Jesse, did you have anything on the church announcements?
I just
I
want
just
to
want to
talk about this just a little for an extra second or two. What do you think? What do you think is behind all of these major code changes? Because I want to say, like last year, they put out something like there were like up like almost 400 new codes. This year is almost 400 new codes. It's a lot going on, and I want like, what do you think is behind it?
Well, from years past, there has always been a lot of code changes, but then we had that kind of blip called the pandemic, and you didn't see a lot of change except for those codes that were related to COVID-19. I think there's a catch up and makeup process going on.
Oh,
I think folks are back actively um, um, doing their work, if you will. So they're finding new diagnoses, finding new diseases, finding new workflows for how to code things, and making appropriate changes in that regard. I think folks are understanding some of the disease processes better, or getting a better understanding of conditions that are included with others. So you don't have to have like a gazillion codes. There's some combination coding things happening. I think there's just those types of things that are going on, and being reflective in a lot of the changes. Um, and I can't remember. There was one area that had the most changes. I can't remember it off the top of my head. And so I guess to that point, I think they're doing a lot of work in that particular area, that they're revamping some of those things. And I think it's a way of lightweight trying to clean up to prepare for ICD-11, particularly if, they don't get the CM and they have to do these workarounds. So I think a lot of things are at play. But yeah, we used to get all kinds of codes, hundreds and hundreds of changes, if you will, prior to the pandemic. So
I don't. I mean, there were always changes, but I don't know. I didn't remember, or maybe I wasn't paying attention, but I didn't really remember like this many. It just seems like it's a lot. And you make a very good point. It really could. Everybody's still playing catch up behind the pandemic for real, for real.
Yeah.
And it's I just find it interesting.
Yeah. That's the lot going on with that, and trying to make sure that things are and I do believe they're trying to do some prep work for what's to come as well. And like I say, it's interesting to hear, because remember, we kind of get the preview at the coordination and maintenance committee meetings. So the changes that are coming in October actually happened. um the information, or that meeting, I think, actually happened in April last year. So it kind of prepares you for some and sometimes they make other changes that maybe they missed, or people brought up, or that type of thing. But for the most part, the bulk of the changes they do discuss at that meeting. So yeah, and then they take into account, the comments from folks. So if they have some comments strongly for or against, they weigh those comments as well to determine whether something is or should not be, or what have you. And then they kind of look and see, well, maybe we can't change it this way, but here's another option. And so then they kind of provide that to see how that. And then, after all of that, you'll get those coding clinics to be talking about, well, wait a minute, we meant this. I don't know how y'all saw that, but this is what we meant. And so they move forward that way as well. So, it's an ever evolving industry behind, again, the mirrors. I won't say smoke, but the mirrors behind all the stuff that is happening in the background that really we don't even really consider or think about as we're doing our work. Good morning. I don't want to butcher your name. Oh my, I want to say Naomi, but I'm not sure. But good morning. Hate to butcher people's names, I swear. Okay, well, let's get into our Gideon. So today we're talking about um, some methods of risk adjustment, and this came from, oh, where did it come from? This came from somebody. It was a white paper, and it came from
On Belay.
huh?
Oh, you talking about the one for On Belay Healthcare, the concurrent retrospective and
Yeah, so
perspective?
it was a white paper. It came. I wanted to get the actual where that part came from, or who first talked about it. So it came from RCX Rules, their blog, and Kate Cassidy posted it. She was their guest writer, Cassidy. I think I'm saying her name right, Cassidy. Okay. So, as you all know, there are a couple of, and Mr. Jesse, I'm going to refer to you from your HCC coding expertise and knowledge as it pertains to maybe even the methods that you may have used. And I don't know if you've used all of these or not, but we'll jump into. So, so according to this particular white paper, there are three different methods, if you will, key methods, main methods for HCC coding or risk adjustment coding. And they are the pre-visit chart preparation, they are the current review, and you also have the retrospective review. And there are pros and cons, if you will, of each of them. Mr. Jesse, do you have a preference on one that you like best versus another?
Well, it depends on what angle, because if you're an entity, you definitely want to do the first two. You definitely want to do a pre-visit and you want to do a concurrent. And then, of course, if you're an auditor, you can only do a retrospective. I mean, well, not only, but it's mostly you'll be doing retrospectives.
Well, especially if you are you could do retrospective as an internal auditor as well. I was thinking if you're an external auditor, of course, retrospective will definitely be the way to go, because everything will be long gone before you get in if you're external. So, okay. So she listed some pros and cons of them. So let's talk a little bit about the concurrent review. In the white paper, says this process allows coders to review the electronic health record, medical notes, and HCC codes in real time. That's before anything hits the payer. So one thing, and I know even as an auditor, there's always discussions on, should you do it before the payment drops or should you do it after the payment drops? And you have multiple thoughts. But one thought as it relates to doing it before is that you can correct it and make sure that it's kind of clean going out the door, if you will. I think this is probably some of that same thought process. Again, this is a significant benefit of a concurrent review process is the speed of markup. So you can get feedback into the hands of a provider very quickly and drive behavior change through repeated stimulus and response. So they are saying that there's really some things that you can help, particularly with the physicians. If they're given the right information, they're going to pick up on patterns really quickly and alter their behavior accordingly. We've had some thoughts on that.
Hopefully they'll alter their behavior.
This is what you would ideally. This is what you would want.
Right.
This behavioral change aspect is unique to concurrent review. The ability to get feedback to a provider right away and improve documentation prior to filing is a game changer. You can't really achieve that feedback model with any other review process. Another strong argument in favor of concurrent review is the accelerated accruals and leading indicators for risk score forecasting. Accurately forecasting risk adjustment scores is extremely difficult. Concurrent review gives you real-time data that can be leveraged immediately, as opposed to other workflows where the data lags behind and may be less useful a few months after the fact. The concurrent review process also offers an early reduction of compliance risk. Including the correct HCC code on the initial claim is a safer option than adding or deleting an HCC after submission. By including all relevant information and ensuring it's correct the first time, you can reduce your audit risk. As valuable as the real-time feed process is, it can also become a negative if it isn't handled in a way that's efficient for both coding staff and providers. So it's important to avoid a situation where the learning and behavioral changes become a burden that doctors don't want to deal with. The key lies in creating a frictionless and experience as possible. The feedback element is also a qualitative process, which can make it difficult to translate into financial terms. And another potential issue is the negative impact on fee-for-service AR. If you tie up a claim for a week waiting for a provider to respond, you can complicate things. When there's fee-for-service and shared savings with an ACO, for example, holding up claims, it can delay fee-for-service revenue. So that's concurrent coding. Mr. Jesse, did you have anything you want to?
Not about, because I think it all comes down to like concurrent. Coding period comes down to having appropriate institutional policy. But I definitely think that if they had more institutional policy and they had more effective provider education, concurrent review would be excellent because it would you could because if that were the case, then you can sail through a retrospective review,
Mm-hmm.
which is ideally the goal. But
Yep,
we'll see.
you're absolutely correct. Okay, real quick on retrospective review. There wasn't a lot of information there. Most of it was primarily about concurrent. Retrospective coding review occurs after care has been delivered and claims have been submitted to the payer. So, in theory, retrospective review sounds like an efficient and cost effective approach. It takes minimal effort to acquire suspect codes to pursue the following year, and groups can leverage cheaper. Where's my tea? Cheaper offshore coders for
Uh
the associated manual tasks. So, why do medical groups seem to be moving away from this approach?
oh.
Well, in reality, as focus on point of care increases, the financial viability of a retrospective review decreases. With point of care being so important, groups need to find a way to work within the provider's workflow. EHR access for offshore vendors can actually be quite difficult. Groups are increasingly finding these obstacles prohibitive and realizing the value in identifying larger issues and proactively working to address them. I agree. Even though for as an external auditor, I prefer the external review because I'm not I'm not bothering you all, and you all are not bothering me. We can all do our work. However, I do understand and know the value in the concurrent and doing things prospectively. So I get that, and I do understand the value in that. But that's for from my perspective, from my vantage point as an external auditor, that's for the organization. So that's for you all to prepare and be ready for when I come. So it would make both of our jobs easier and lighter, if you will. Any thoughts
And
on retrospective? Go ahead.
well, when it comes to risk adjustment and HCC coding, period, like I didn't find this out until eons after I was working in risk adjustment. But um, codes are only submitted 3 times a year.
Mm-hmm.
So because risk adjustment, you are projecting payment. So um,
I'm reading what Vicky said.
yeah.
I will show it in a bit. Go ahead. I'm sorry.
So there, there's twice a year where you report for the next year, for the upcoming year. Then there's another period where if you catch if you catch anything that needs to be adjusted, you can resubmit before that date to correct whatever it is you submitted prior. So that's where retrospectives really, really can pay off because you can have a chance to basically catch up. And if you need to, optimize something, then you have an opportunity. Or if you need to correct something because somebody was overzealous, you can do that too. And it'd be better to do that than, get hammered, 2 years later.
Right. As we continue to see with all of these reports that are coming out. So Vicky said, I'll share this. Jesse, how dare you call them providers? How dare you?
Yeah.
They're better than that. Remember last week?
Look,
Uh,
I apologize for minimizing their compassionate
oh
sacrifice.
my God. Just the spewing
Oh,
in sarcasm. I love it. I love it. All right. So the other thing is the prospective review or pre-visit planning. And so this is about getting ahead of the encounter, which in theory helps groups get ahead of potential problems. In reality, pre-visit planning works to prime providers for the visit and increase the chances of complete code capture. Doctors are busy, and realistically, they're not going to read a complex pre-visit report in detail. But a concise, well done prospective review can prime a provider with relevant information. When done right, pre visit planning can give a provider enough relevant context to be clinically useful. It also works to establish accountability through prior clear knowledge. Pre visit planning requires a suspecting engine to be most effective. It's labor intensive if done manually and can't be easily outsourced. It can also be difficult to find the optimal workflow. Teams need to understand exactly how the provider prepares for the visit. When pre visit planning really becomes valuable is when it's used in conjunction with concurrent review. In this scenario, the pre visit prompts set up a provider to follow up and capture relevant information, and the concurrent review process ensures that nothing is missed. So, those actually are the three um, key methods for risk adjustment coding. You have the pre visit chart prep, the concurrent review, and the retrospective review. So what types, and this is open to those joining, what types of reviews are you familiar with or have you used in your particular organization, and what are your thoughts on what works for you? Feel free, use the comment, jump in the chat. Mr. Jesse, do you have anything?
Well, I actually like concurrent and I like retrospective, especially if they're done. Well, anything works if it's done correctly.
Of course, of course.
But I just think that um, people have just gotten away from the basics, and there's a reason. Like, systems are in place for a reason. I mean, it's CMS didn't come up with this risk adjustment methodology to be punitive, and if it's used correctly, you can really optimize some revenue.
Mm-hmm.
But that's the whole thing. You have to use it properly, and you can't use it as a money grab. You can't do anything for a money grab.
And unfortunately, I think, and I don't know, and I don't think it's the providers or the physicians or any of the practitioners. I don't think it was their intent. I think it's on the financial side. I think they thought, oh, wait a minute, snap, here we go. Here's a way to um to get some additional revenue, or make this an additional revenue stream, if you will. I think they thought, well, we know the based on data, we know the type of patients that we see. We know some of the losses that we've occurred because of some of the treatment that's needed for certain categories or types of patients with certain diseases. Um, I think they felt, okay, well, here's a way that we can kind of save money, potentially save money to the patients, but also save money for our organizations as providers to kind of make sure that we're doing all this because they give money for them and with their cost savings, they being CMS. However, I don't think they understood and realized, and again, in my mind, it all could be so simple because really it's just saying this is the diagnosis that the patient has.
Right.
I have managed provider documents. I've managed, I've seen, I've evaluated, I've treated this diagnosis within this time frame for this patient. There's clear documentation. You're good to go. Everything sells. Your that revenue cycle or revenue stream dream that you had comes to fruition. The problem comes in is where somebody, or it's an automated process, takes all of the conditions that the patient has and just dumps them on every encounter. And then the person who's doing the risk adjustment coding Or if that's an automatic process, then it just takes what it gets and pushes it along. So everything is just moving along and nobody is eyeballing and say, whoa, 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 whoa. Do we have some documentation to support that? No, they just send it. Like, to your point, these things are due at a certain time interval throughout the course of the year. They're just pushing the stuff along and sending it along without taking the time to validate that the information has been documented by a provider within that time frame. To me, especially when I hear about the issues with cancers and history of cancers, that's a no-brainer to me. Like, really? So that's what makes me think it's some automated behind the scenes something is pushing something into that current documentation or current encounter. Go ahead. I'm sorry.
I just want to make one more comment. Then Renita has a nice comment in the chat. Whenever for me, like whenever I was doing retrospective reviews, because when I see somebody, whenever I read it or did a chart, and I saw an active cancer was coded and it should have been a history, I'm like, I know that they have no effective concurrent review process because somebody should have caught that.
Right.
That's really not hard. Like when I see that, and when I see acute MIs in an outpatient setting, really no.
Some of the stuff is like common sense. You know what I'm saying? And again, you would think that the entire process would have been strategically planned up front. These are the steps that need to happen. Here's the policy that designs all of this, and then here are the procedures that outline the steps that should happen within this type of coding, which would optimally provide us with the results that we're looking for. Something broke down. Something ain't there. There's a weak link somewhere. Renita says, good morning, and good morning, Renita. Post-review recouped on my end. They don't want to listen or desire to change. So I sometimes feel I'm chasing my tail. I'm not a coder, but now a lot of the E&M denials are being, she dropped off. Oh. Wait. She came back, but I'm chasing my tail. Know better, do better. They don't want to change. Okay. Yeah. And I'm this E&M thing, I'm just sitting back because I've been waiting for this one. I have been waiting. I have been waiting with bated breath to see like how is this working? How is this working out for folks? Because yeah. Things in the game done changed. Go ahead.
And I think anybody, even everybody who is in the trenches can tell these organizations exactly what the problem is. They know exactly where and what the problems are. But it's just it's just people are afraid to speak truth to power. And we have created an environment in healthcare where basically physicians are like unruly adolescents. Like healthcare has really created monsters, and when they try to reel them in, it's just like they go kicking and screaming. It's like you're in Walmart and hear a child in aisle 7 screaming and hollering because they can't have a toy. Like if you do what you're told, you can get the toy. and they just don't. It's mind-boggling to me because it's like, I mean, it could not be any simpler. Coding and healthcare and revenue could not be any more simple. There are established guidelines and rules. All you got to do is follow them. That is all.
Follow them. They're right there. They hand it to you. Yes. Hey, Nicole. Nicole says, and also it would be amazing if providers all over the world would come together, stand up to insurance companies, and resist the obligation of seeing patients every 15 minutes. It reminds me of the, back in the day. Oh, wait, she got some more. So the truth about patients can be documented, opposed to get them in, get them out. It's production. It has become production. I think there's blame to go around. The insurance companies have a role in it, if you will, because of the denials and not paying and some of the games you got to play and trick bags you got to work through and walk through in order to get your payment and keep your payment. But you also have to look at some of the financials within certain organizations, because most of that is partly the reason for the push. Get them in, get them out. You need to have, and physicians play a role in this, because and I'm speaking primarily to those who are, I guess it can go across the board to those who are in private practice as well, but I'm speaking specifically to those who are employed. You looking for your bonus. You trying to aim for that carrot. And so you're going to try to generate and maximize as many RVUs as you possibly can. So you want to crank that wheel, get them in, get them out. And unfortunately, I don't think folks really sit down and realize the importance of the documentation. It's been that way since the beginning of time. You got to write it down. If it's not documented, it didn't happen. We remember that was drilled into us forever. I would have thought that would have been drilled into all healthcare providers. And that takes time. So yes, it takes so many minutes to see that patient, but it then takes time to make sure that you are completely and accurately documenting those encounters. Folks, and I've heard from some providers kind of recently that talk about, and some of them seasoned and some of them are new, talking about the additional, well, I got to take all these charts home, or not home, but I got to do extra work after hours or whatever. Log into the system. That's how I'll say. Log into the system after hours or at home to do my charting. And I'm like, well, to me, that would indicate a conversation needs to happen. Collectively, we all need to sit down and figure out, well, what's the optimal workflow for this? Should we try to stack these like they do at the hair salon, where you got 5 people who's supposed to be here at 5 o'clock? No. Now, I know that it's a different time in healthcare. I actually sat back and witnessed. I was sitting in a provider office, physician office. I'm sorry, physician office. Okay, I'm sorry. Sitting in an office, and they were explaining their no-show rule, no-show policy. Like you had to sign off, and it was like for every patient, and the cost associated with no showing, and then after no showing for so many times, you're no longer allowed to see this provider at this practice. I guess they are seeing a lot of people who make appointments and for whatever reason don't show. So they try to, I guess, incentivize it where people are not doing that, and then ultimately you will be removed from the practice. So I guess that's a way to try to make up for the money. But so my point in saying that is, I kind of understand well, maybe if we had another patient in the gap, we could do that. But then you got to think it's only one provider for that patient, and that you're gonna slow up that they're not thinking. They want it to operate like production, but they're not putting in the logistics of production, if you will. I think somebody's not, because then it's not mathing.
So now doctors' offices have become Rashida's bump and curl.
And let the shampoo girl not show up. Oh Lord, it's a whole situation.
Exactly.
Or let something, it's production, and it's unfortunate. But even in the production, I don't think they have factored in critical pieces such as time for documentation. Yeah, you got, if they slot you in for 15 minutes, so are you supposed to see that patient at 8 minutes and document for 7? I mean, at some point they need to, and that can't be the case all the time, especially depending on the population of patients that you see. See some elderly folks, they gonna talk to you.
Ooh.
Now, you may be the only person they done talk to all week, and they've been waiting just to talk to you. Hey, doc, how you doing? It don't even be about their condition. They just want to interact with somebody, and you are it for the day. So how do you factor in that and plan for that? I think those are some of the things or challenges or discussions that should be had that will help kind of move this healthcare continuum. Like, what about those things? I know you're trying to get to the money, but get to the money the right way. Get to the money, the best way you can. Mm-mm-mm. Let's see what Nicole says. You say, honestly, I cannot and do not want to think that fast. Recently, I've received private practice notes, shaking my head. I could say so much. Documentation has fallen through the cracks badly. It's horrible. Trust us, we see it. We see it, which is why you then have your CDI departments, which is why they have to tap folks on the shoulder or query them and ask them questions about things that should have been documented at the time of the visit or concurrently or whatever. And then now they're like, oh, it's too much. Y'all keep bothering me. I just want to see the patients. I just want to do this. But that's all part of the work. And if you would proactively do the work up front, all of the stuff, you wouldn't have all of the stuff that you're doing. She said, yeah, the talk, I was wearing a mask just to hide my facial expressions as I read the lack of documentation. And then she said the patients talk for 15 to 20 minutes. Exactly.
Easy.
So that I know you're thinking, oh, well, this will be, a 8-minute visit, and maybe we can put 2 or 3 of them on the time slot. But then you got this patient that's going to come in and talk for 15, 20 minutes. You might have one that don't say a word, but then you have one that may overcompensate for that one. And then now you are behind. And so as consumers, we come in, because the first thing I ask, like, how far behind are we? So I have a mental picture before, I go out. And so you got to take into account, particularly if you have a doctor that is a great doctor and everybody wants to see that doctor, they're gonna always be behind unless they factor all of the things into what a true visit looks like. And time is money, and you only have so many so many hours in the day, so many minutes in the day to see all the patients that you have lined up.
And can we talk about how it is, especially when you said something key, a doctor you want to see? Can we talk about how you have to wait months for an appointment now?
Months. You be calling in like, hey, I'm just trying to get an appointment. They be like, March.
Exactly.
Like, my order will be to fall off in March by this time. I mean, what? So with that, consider this. Well, if it's because even in emergency situations, oftentimes I don't even know if they have the slots available. I know they used to have like some quote unquote, well, just in case emergency slots. That I don't even know if those things exist anymore. And so then the patient is pushed to emergency, and then now you have that extended wait time in emergency and additional fees because you got to pay more money when you go to emergency. Or you have the option of urgent care, but urgent cares are often same type of situation. You're waiting for periods of time, and there's an additional fee with urgent care that may be higher than what you would have paid if you would have seen your physician or practitioner in an office. So all of that is just I don't even know where to begin with that. Except at the schedule. Schedule is right.
You know,
Plan for it.
we might have to have a Saturday morning tea about urgent cares. Because can I tell you, I don't understand them.
Yep.
Because
Let's write that down.
because when I'm reviewing records, most people who go to the urgent care end up in the ER anyway. So why not just go to the ER?
And so somebody that made some money on top of some money.
Because I went to one and I'm like, no, there's only one that I went to in Maryland years ago that was actually worth it. And I think I had like strep throat or something. And they, did all their tests, gave me my prescription, and I think they even filled it there or nearby or something. That was the only experience. I mean, what when I read records, it's like person went to urgent care 2 days ago or a day ago, and they still have the same symptoms. Most of the time now, when you go to urgent care, they can't. If you're not there for like a nick or a cut, you might as well just go to the emergency room. And if you have a serious nick or cut, you better go to the emergency room anyway. I don't get it. I don't get it.
Again, I think we will add that to a Saturday morning tea because I think I understand what their initial purpose was to be the quote step down, maybe at a lower cost and with more options. But to Nicole's point, they're now on every corner, making money. Some of them you look at it like, is this place really open? Because it looks like Amityville horror in here. I'm nervous from the outside. It's dark. It's scary. It's spooky. I don't know. The other part, a lot of urgent cares to me, I've seen because they don't have to be open 24 hours like the emergency room, but they only off 9 to 5. What really? Can somebody get some evening hours? I mean, where that just don't exist.
And some of them don't even do refills. Actually, most.
I don't know.
Like, I mean, I could see if somebody's coming in and they want a refill of Dilaudid. Okay, I can see that. I can see you having a problem with that. But now somebody coming in for a refill of Ventolin, it's an inhaler. What are you going to do with an inhaler?
Nicole, I don't like you right now. If you see a Chipotle, you will see an urgent care. I don't like
I love that.
You gonna have me looking every time I travel past the Chipotle. I'm gonna be looking for. I'm gonna come back with some data on that. Have a whole bar graph and chart as well. I don't know. I just, really, it just all comes down to, we and I'm gonna say this. I may regret it. I don't know. But because someone wasn't strategic in the planning of all of these things, not only are the physicians overwhelmed and overburdened and all of those things, but they're not the only ones. Everybody is feeling the pinch of someone not properly preparing for healthcare.
That's
period.
Right.
So it's not just y'all. I mean, y'all got the money and want to talk about it and tell everybody y'all woes and pains and cry and all of the things. But but we all feel it. We all everybody feels it. We all feel it. When at some point when you talk about let's do a whole overhaul of healthcare, let's start there. Let's start with understanding that what they say now. Today's price is not yesterday's price.
Yes.
Today's time is not equivalent to yesterday's time. It's a whole different world out here. And let's make those changes appropriately.
Yeah. Well, I like what Renita said.
Urgent care is the triage for ED. I know that's right. Like, And then do they pay attention to that? Do they send the records? I mean, because then you got to go back and redo the whole thing. Oh my God. A friend of mine told me a relative has a doctor. They call the doctor. What the doctor tell her? Go to the ED. I said, what? I was like, it was like, even if we go, they'll say, go to the ED. I'm like, I don't understand that. Like, I don't have time. Let somebody else do something, get some fresh eyes on it or something. I don't know. Like, are you kidding me? And y'all still go to that doctor? You would be fired.
Yep.
That's
crazy.
And this is a whole other conversation. But yeah, the food out there is really messing people up to need more medical care, sad but true. Yeah, I think there's a lot of things going on with the food, but you got to make that's a choice. Folks make choices about what they put in their mouth.
Oh. To a point, because because I have a friend who is an on again, off again vegetarian, and that's fine. Look, I don't knock anybody. And
now I'm a vegetarian. You better treat.
I understand. Okay. and I get the people, because for me, like, you can't tell me that meat is bad for you at the same time when you're eating genetically modified carrots that have been sprayed with all kind of insecticides. We all gonna die. We all gonna die. You just picking your poison. I mean, none of at this point in the United States, no food is safe, not even the water.
That's true. This may be the Big Pharma and the FDA are buddies.
Oh, that's fact.
They cuddle buddies.
That's fact.
Yeah,
that is big fact. Because we think healthcare is in peril. We're not even going to talk about the pharmaceutical industry and how they, like, I saw a documentary a couple of years ago. Ages ago. It was about maybe 5 years ago.
Mm-hmm.
And it said the statins were the most profitable drug in the world.
My friend told me probably 10 years ago, maybe 15 years ago, do not ever in life take a statin. And I have held true to, and I tell people all the time, don't take that drug. Don't take that drug. I don't know what else is out there. I don't know what else you can work around. I don't know what's going on. Maybe it's something that you could prevent by doing some other things yourself. But she told me not to take that drug, and I have been true to that.
And because people don't understand, like, I've been a nurse for 30 years. People don't remember, and I'm sure you remember, Clarice, because being in coding. The standard for your optimal cholesterol level has been lowered as time goes on to allow for the use of these medications, because we need to be very clear. Your body every cell in your body is made of cholesterol. You need cholesterol.
Mm-hmm.
A certain amount, 'tis true. But the standard used to be 300. Then they lowered it to 200. Now I believe it's 150, because I had my cholesterol checked when I was in the hospital. It was 178, and they, well, you know how the nurse comes in and they're like, I have your medication. I'm like, well, what's this? This is some kind of a atorvastatin or something. So I asked my doctor. I'm like, well, first of all, like, what was? I had to pull it up. I'm like, well, what was my cholesterol? My cholesterol was 178. Why am I on a statin? Oh, it's preventative. No.
Who? Why would you wreck your? Oh
no.
My God. Oh. Preventative.
But can I tell you, I have had my best friend, her husband, just had a heart attack about 2 weeks ago. He was on a statin, and high blood pressure medicine. And he's like this big. And I I mean, I do reviews all the time where everybody is not non-compliant. These medicines don't work and they recapture your body, especially statins. Because people don't know that if you take a statin, you have to take coenzyme Q10.
Oh God, I don't understand. Yeah, and then everybody's makeup is not the same, and then we actually have culturally, racially, things that are part of why certain medications don't interact with people. I mean, there's been studies that have shown that. So you can't blanket prescribe a medication based on some data that may not necessarily be applicable to all racial makeups. You can't do that. And now, well, that's a whole other conversation. That we're all blended and everything. That who knows what's gonna work for whatever. And come on, y'all. That's why you need the time to have conversations and review data and look at documentation for each individual patient that you are encountering, to make the appropriate decisions on their healthcare needs. Period. You can't just be like, oh, they got this. Oh, well, everybody get treated with this, and this, and this for that. No, that's not the jam. That's not the jam.
Oh, so speaking of the FDA, did anybody here? Because I think I read this a couple weeks ago that they have allowed. There's some kind of change that they made to lower the standards for what can be considered organic. I mean, I'm not at all surprised, but I'm like, what in the world is it? Exactly.
That is a money grab, because then they see people who are actually out here trying to purchase organic things, and so it's like, oh well, wait a minute, if they're gonna spend that money, let's make more of these things that are not necessarily optimal to that standard. Let's just reduce that standard so we can push more things out here so they're back. Come on, y'all.
Mm-hmm.
Come on, y'all. She said there's never been a death certificate with the cause is high cholesterol. Never, ever, ever, ever. So much education needed so that people can self-advocate. Yeah, let's see. So true. I took a patient off of lisinopril because it is not the best choice for African American people. There are, I had to do some research on that. There are so many studies that support that. So many. And do the providers understand that, and do they know that? And are they aligning and following that? Again, based on the individual patient. Like, come on, y'all. Come on. Come on.
Well, as always,
we go all the way around the world.
Mm-hmm.
One thing triggers something else,
and it's all related. It really is.
Related, all relative. You are absolutely correct. Yeah, and we talked about this before about the challenges with healthcare, and it's so complex. But does it really have to be as complex as it is? Does it really have to be? Think about that. I'll let y'all chew on that this week. Woo. Well, this was a good one. Yes. So, well, thank you all again. We are at the top of the hour for joining the Saturday morning tea and checking out the replay. Oh, I did. The Patreon is so if you're on, I think it's on all of them. If you look at the description box, the Patreon stuff is there. We got some wonderful things coming up. So stay tuned. If you want to be in the know, make sure you hit. Just go out to the Patreon and click the link and just get some information, and you can decide from there your course of action. But We got some stuff coming up in the works. I'm excited. Mr. Jesse has signed on. I'm so excited. Oh, I love it. I love it. She was like, you need to pass the offering plate this morning. This has been juicy. Y'all see my cash app there. Don't play. Don't play.
I mean, I'm not just saying it because it's, us or just because, but honestly, like this platform,
This is information.
and it always has been consistent.
Yeah.
Like this is not new for us. This is every week for a good year or more now. So,
Yeah.
it's amazing how people can fall for the okie doke, but you have some real information out here, and people want to brush by it, but it really that's why I'm a part of it, because I've always told you, and I've always appreciated you even creating this platform, and not only creating it but keeping it real, because a whole lot of people will try to do things to get views and to get out there, but you got to be true to what it is you're doing.
Yes.
And eventually people will come, because the truth will live forever. It is what it is.
It is what it is. Yes. To your point, we are not new to this. We're true to this. And really, those who know me know that I'm a resource. If I find the information, if I find something out that I think will help somebody, that's what this whole thing has always been about, providing information to help people do the jobs that they need to do, period. And sometimes it doesn't look and feel warm and fuzzy as you need, and sometimes it allows you an opportunity to do some self-reflection and considerations. But it's there. It's put out there. Have a conversation. Maybe things will change.
Right.
Ultimately, that's the goal, right? Right.
Ideally.
And put truth to power. Speak on it. When you say something, when you see something, say something. Like, because some of the stuff we be saying, come on now. Come on. Call a thing a thing. I feel like Dr.
Absolutely.
All right. So we have all assessed that the tea was spilled today. Yes. If this information was valuable for you, then share the information. Other people may need to know this. Send them to the channel. Let them take a look for themselves. Send them to the Patreon. Let them take a look for themselves, seeing if this is something that would be vital and helpful for them. Also, if you have information or suggestions for things that you want us to do a deeper dive in, reach out. Let us know. We will definitely make considerations to bring things to our Saturday morning tea, as well as our other offerings that we will be providing momentarily. All right. So make sure you follow us for information on all things health information, compliance, revenue cycle, and medical coding. And remember, as you leave, don't forget to hit the thumbs up or like button. And of course, you can subscribe to the Professional Reimbursement Network's channel, as well as the Coding Nurse channel, where he drops, y'all think he drops gems over here, Lord Jesus, where he's dropping the gems over there as well. So thank you all. This has been a great session. Couldn't have done it without you. So thank you for joining. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care.
Bye-bye.